Hemodynamic Effects of Positive Pressure Ventilation by Melissa Pride. Objectives: to illustrate spontaneous breathing in relation to cardiopulmonary and systemic circulation, with mention of synchronicity and synergy. To provide context illustrating the effect of positive pressure ventilation, as well as illustrate some of the compensatory changes within the cardiopulmonary system. When the body needs oxygen, a series of signals travels throughout the body. These signals, when received by various receptors, are interpreted and responded to in many ways. Blood is always flowing through the circulatory system to and from the heart. The lungs are always taking in air and eliminating carbon dioxide. These two dynamic processes take place within the thoracic cavity every second of every day that your heart is beating and your lungs are breathing. The air we breathe enters into the bloodstream when oxygen molecules reach the alveoli and diffuse across the alveolar capillary membrane and attach to red blood cells. A series of feedback loops communicate from the medulla to the sympathetic and parasympathetic nervous systems to respond to the changes in cardiac output. These tell the heart to pump faster or for the vasculature to constrict. Increases in thoracic pressure cause the lungs to expand inside the pleural cavity. This also exerts pressure against the pericardial space, decreasing cardiac function over time. Pleural pressure is typically negative. When we introduce positive pressure ventilation, this becomes positive. When understanding the changes in cardiac pressures, it's best to understand what the normal values are in a spontaneously breathing patient. Right atrial pressures can vary with respiration, from 0 to 4 millimeters of mercury. Right ventricular pressures are typically 25 millimeters of mercury systolic and 4 millimeters of mercury diastolic. The pulmonary artery typically measures around 25 centimeters of water or millimeters of mercury systolic over 10 diastolic, while the left atrial is 8 to 10. The left ventricular measures at 120 millimeters of mercury systolic over 10 millimeters of mercury diastolic, while the aortic pressures measure at 120 millimeters of mercury systolic over 80 millimeters of mercury diastolic. When we breathe spontaneously, the negative pressure created by the contraction of the diaphragm allows air to easily enter the pleural cavity. When air is forced into the pleural cavity and not generated by negative pressure, the overall thoracic pressure is increased and further exerted on the pericardial sac. This can change our hemodynamic status. Each breath increases airway pressure, alveolar pressure, intrapleural pressure, and intrathoracic pressure. This can be observed on a cardiac monitor with changes in pulse pressure and with oxygenation. Positive pressure ventilation with the use of PEEP, positive end expiratory pressure, in order to prevent alveolar collapse, can also work against cardiac function in healthy patients. Here are the 4 major effects that positive pressure ventilation can have on a patient. Other than decreasing left ventricular afterload, PEEP also decreases the left ventricular diameter. This could lead to a decreased mitral regurgitation, and the side effect is improved cardiac output. If the mechanism is increased transmural pressure, this can also improve cardiac output. If the alveolar pressure is increased at end expiration, this can improve compliance, preventing alveolar collapse. When positive pressure ventilation elicits changes on gas exchange, this can reverse hypoxic vasoconstriction, which would lower right ventricular afterload. If the gas exchange decreases in preload, this could improve pulmonary congestion. If gas exchange improves ventilation and VQ mismatching, or perfusion matching, then we see improved oxygenation. When positive pressure ventilation is used to improve work of breathing, we can also see improved tissue perfusion. Improving this perfusion can decrease myocardial consumption of oxygen. When we improve hypercarbia or acidosis, we improve right ventricular afterload. There are systemic effects of positive pressure ventilation. This optimizes gas exchange, hence oxygenation and tissue perfusion. This leads to improved metabolic demand and peripheral perfusion. Excessive pressure in the bronchioles and alveoli can overdistend and obstruct blood flow around the alveolar capillary membrane. Prolonged exposure can trigger cytokine and inflammatory chemicals that could cause respiratory distress. Increases in pressure on the pericardium during inspiration can increase arterial pressures systemically. Microcirculation ultimately dictates cardiac output. Positive pressure ventilation provides extrinsic forces the body must overcome to maintain homeostasis in blood pressure, circulation, and overall cardiac function. The increased systemic vascular resistance decreases flow into the right atrium, decreasing ventricular preload, causing a decrease in blood pressure and cardiac output. Cascading the effect of preload, afterload, and contractility in a newly elevated pressure system. The pulmonary artery pressures are elevated during positive pressure ventilation and can be observed via pulmonary artery catheter tracing. Baroreceptors located in the aorta detect an increase in the pressure over a series of beats and sends impulses to the medulla. Those receptors over time accept the elevated pressure as normal and decrease the number of impulses sent to the medulla to regulate cardiac output. Both the respiratory and circulatory system work together to moderate the homeostatic balance needed to deliver oxygen and nutrients to the tissues and organs while eliminating metabolic byproducts. When receiving positive pressure ventilation, increases in pressures across the body facilitate compensation on a variety of levels. With each positive pressure breath, the airway pressure and alveolar pressures compress the right ventricles and left ventricles. This decreases venous return and decreases preload in the heart. While positive pressure ventilation decreases left ventricular afterload, there is an increase in right ventricular afterload observed. When ventilating our patients, we must be an advocate for them, their lungs, their heart, their circulatory system, and the tissues. We control the amount of volume entering the lungs, the pressures, the FiO2, and other parameters. To ensure safe lung protection strategies using minimally invasive techniques or minimal distending pressures that promote oxygenation or ventilation in an effort to safely ventilate the patient while their underlying issues are being addressed. Well, do you think you got it? It's time to take a quiz.